Good afternoon, everyone. Thank you for joining us today. I am Adelisa Perez-Hudgens, Director of Quality at the New Jersey Healthcare Quality Institute. The Quality Institute is a nonprofit organization focused on improving the safety, quality, and affordability of healthcare for everyone. Before we get started, I wanted to go over a couple of housekeeping items. Please know that this webinar is being recorded and a copy will be posted to our website at www.njhcqi.org later today, and I'll also be sending it to everyone attending in a follow-up email after today's event. All phone lines will be muted for the duration of the program to limit background noise, but please feel free to ask questions by typing into the chat box. We'll try to answer them in real time, or we will definitely get to them at the end of our panel discussion. And so with that, just a little bit of information to get started here. The Quality Institute oversees a statewide community health initiative called Conversation of Your Life, also known as COYL. We can't predict when a medical emergency will happen or if a serious illness will come along, but we can plan ahead. We can talk with those who matter most in our life and to our healthcare providers about what matters most to us if we were to become seriously ill. And COYL aims to help you do just that. We engage communities and residents in crucial conversations around what matters most to each of us and how we can plan ahead. We discuss topics such as treatment options available to you, how to communicate your wishes to your family, friends, and your healthcare providers, legal considerations, and how to legally document your wishes. We want to make sure that you have the information and resources that you need to help you make decisions about the type of care that you want. Our programs are available virtually and in person throughout the year and in various languages. Today's program is called Essentials for Caregivers, a lesson on palliative care. At some point, each of us may find ourselves caring for a family member or friend with a serious illness or chronic health condition, and this might even be you today now. We're going to talk about what palliative care is and how it can help those who care for live better, and how it can support you as a caregiver. And if you're a patient yourself, you're still going to learn valuable information today about palliative care and some resources that you can share with those who care for you. We're honored to have a panel of experts joining us today, and I'd like to ask each of them to go ahead and introduce themselves. I'm going to stop sharing my screen here so that you all can see everybody, and I'll just go in the order of my screen. So Ellen, you're up first.
Hi, everybody. My name is Ellen Kohler. I am a licensed clinical social worker here in New Jersey. I'm currently the clinical director for an organization called Integrative Psychology Services. We provide in-home, in-facility, and virtual psychotherapy to adults, very heavy on seniors, very heavy on our caregivers. And I come to this position after a 20-year history in home care and hospice social work and administration.
Thank you, Ellen. Dr. Burrill?
Sure. I'm Dave Burrill, and I'm a geriatrician, and I work in palliative medicine and geriatrics at Penn Medicine, Princeton, and I've been out of training about 20 years or so. I've also started Goals of Care Coalition of New Jersey, which is an entity we can talk a little bit more about when it's my turn to talk, but it's an effort to improve decision-making and palliative medicine services across the state.
Thank you. And Yusimi.
Hi, my name is Yusimi. I am a nurse practitioner, and I currently do practice as a nurse practitioner in palliative care for the Valley Health System. And I also am the president of the New Jersey Palliative Care APN Consortium, which is a group of clinicians who have all gotten together trying to increase education and access to palliative care throughout the state of New Jersey. And thank you for having me here today.
Thank you for those introductions, and we're so glad to have you guys here with us today. Let's jump right into the discussion. There's a lot of confusion over what palliative care is exactly, and many people think that palliative care is just for those who are near the end of their life, or they think it's just for individuals who are seriously ill, often with a cancer-related diagnosis. Yusimi, can you help us better understand what palliative care is?
Of course. So palliative care is specialized medical care focused on relieving the stress and the symptoms of a serious illness. It is appropriate at any age, at any stage of the illness, and you can have it along with curative treatment. It is a team approach to care, and we consider ourselves an extra layer of support to both the patients and their families, with the goal to improve our quality of life, or your quality of life. at least you're muted.
There we go.
Have to say it at
And I
least
invite the
once.
other panelists to jump in, you know, as they feel comfortable doing so. But there's also a lot of confusion over who can benefit from palliative care. Can anyone elaborate on who is right for this type of service, who should be receiving palliative care?
Yeah, I mean, I can pipe in. The palliative care or palliative medicine is really there available, or should be there available for anyone facing a serious illness, regardless of age, and is carrying a serious illness burden. So, you know, we typically talk about life-limiting illnesses. What does that mean? That means it may be COPD or emphysema, or maybe even a cancer that may be shortening your life. There are patients who will continue to get curative care. They want to go to their pulmonologist, they want to go to their cancer doctor to continue getting therapy to prolong their life. But those people may be burdened by symptoms, right? Coughing or weakness or insomnia, any kind of symptom. And the palliative care service or service line or practitioner has expertise in managing those symptoms. So like Yusimi mentioned, it's really about improving quality of life for people so they may continue with their so-called curative or life-prolonging care. Muted again.
And that's a good point when you bring up quality of life, because that can look different for each person. Everyone really, how their quality of life, what that means to them could be simply, or you guys actually should give some examples of what quality of life can mean, how it differs from one patient to the next. Do you have any thoughts on kind of how that differs for people?
Yeah, you know, it's everyone. What I find especially interesting and fascinating about this kind of work is that everybody's different and everyone's goals are different. So that makes my job, our jobs, really interesting because it's not a cookie cutter approach. And I often tell this story of meeting two patients over a course of a week in the hospital, and both patients came in with the same exact diagnosis. Both had pretty bad strokes. They were both in their 80s and both couldn't walk, couldn't swallow. And they both were the exact same diagnosis, exact same prognosis. So on paper, they were the same kind of case. All the doctors were talking about these two cases. But when we spoke to each of them separately about what their hopes and goals were in the remaining time, they were completely different. And one wanted no surgical intervention with a feeding tube, just wanted to be comfortable at home. The other wanted to live as long as they possibly could, even if it meant going to a nursing home with a feeding tube. So everyone is different. And that's, I think, what is kind of fascinating about this kind of work, I think, for medical practitioners and palliative care specialists. But we're really focusing in on what's important to the patient and what's important to the family. And palliative medicine takes a very holistic approach.
Well, that's great to understand. And you did mention too, sorry, Dr. Brown, I just have these follow-up questions for you, but you also mentioned palliative care service line and healthcare team, and anyone can feel free to jump in, but what do you mean by that exactly? Because some folks, when they think about palliative care, they think of it as terms that they're going to see their primary care doctor or their specialist doctor, like their podiatrist, foot doctor. Yeah. They think of it being one individual, but palliative care is so much more than that. Can you guys talk to us a bit kind of what that looks like in terms of the team approach there that you mentioned?
Yeah, so the promise, I should say, of palliative care, what it does is we focus on what the personal goals of care are for that person, and we look at the whole person and the whole family. In the context of the family, what's important. So it's a big responsibility, and I think it's a responsibility that the primary care doctor had years ago. But as everybody on this call knows now, we've lost the primary care doctor in modern medicine. So the primary care doctor no longer comes to the hospital to see their patients when they're sick and so on. And we have a lot of specialists driving medical decision-making and not great communication in New Jersey amongst those specialists and the primary care doctor. So often what happens is the patient or the family are stuck being the quarterback and trying to piece all of this information together. What the palliative care service does is kind of try to reassemble the person and reassemble the care and try to coordinate the care a little better. It's a big promise. And I worry about painting this beautiful picture for your viewers and listeners because it's not entirely available. So 20 years ago when I left training, there were maybe 10% of all US hospitals had palliative care services there available for patients who needed them. Now it's about 90%. So most hospitals have some kind of palliative medicine service line where we can go and see patients who are really sick in the hospital. But it's really hard to access outpatient palliative medicine. So once you're home and out in the community, it's difficult to find.
And to expand on that, part of what we've done is we've had to partner with different organizations or even within our health system to try to get this additional support. And it's a multidisciplinary team where we try to have social workers to try to help with resources and even the psychosocial aspect for caregivers, the difficult piece of caring for a loved one at home and how do you manage that. We have chaplains, people that you can speak to, and really for spiritual support, not so much religious based, but somebody to have to talk to. And we've tried to also get nurses and physical therapy, home care, really trying to make it a comprehensive treatment plan. And a lot of what we do is that coordination of care, making sure that all the specialists are up to date, that we're reaching out to everybody so that the patient and the family really has an understanding of what's happening and what those options are. And knowing that the treatment that we propose aligns with what matters most to them.
And you both mentioned hospital-based as well as outpatient palliative care services. And so what if I think that palliative care might be right for me, or I want to talk to someone more about it? How do I get started? Who do I talk to first, or how do I access palliative care in either setting?
So I can answer that. We, as Dr. Burrill mentioned, most hospitals now do have a palliative care team. So your primary care doctor or your specialty doctor, if you're going to the office, you can ask them if they're aware of a palliative care program that they can reach out to. You can also go on getpalliative.org, which allows you to also check off home or clinic and see if there is a program in your area. So for instance, we do home, we have an office and we have a palliative team, but not everybody does yet. And I think that that's now where the growth is for us and trying to get out to the community so we can meet people where they are.
So if I wanted to, because you mentioned getpalliative.org website, can I look up and call the palliative care service or facility myself, provider, or do I need to still go through my primary care doctor who has to refer me into the program? Is it something I can, access myself, or do we need that connection with a referral?
I always check with your insurance first to make sure that you don't need a referral, but for the most part, people can, if you don't need a referral to go to your primary care doctor or for a specialist, you probably won't need a referral. We try to always make sure that the primary care doctors are aware that we're involved because we want to be able to collaborate care with them. But we're always happy to answer questions and if anybody else has any input on that and what they do.
And I'm glad that you mentioned insurance because quite often many insurances do cover the cost of palliative care, if not fully, then in some combination of supporting those services. Are there resources out there to help individuals, families who may want to receive palliative care services but don't have insurance? How do they go about providing for these services? And there may not be resources available, and that's an okay answer. It's just good for folks to know. And I see Dr. Burrell's shaking his head now, so you want to?
Yeah.
And not if you don't have insurance that I'm aware of, but just a reminder to anyone on the presentation today, if you happen to have concurrent home care. Yusumi mentioned you can be seeking your curative treatment and have palliative care at the same time. And I just wanted to go back and underscore that, because I found that so often patients and caregivers, there's a little bit of lack of knowledge about what insurance, whether it's Medicare or something else, covers. So if you do have home care, you can, if it's available in your area, have concurrent palliative care. And that's where you really want to utilize, going back to my colleague's mention of the interdisciplinary team, your home care social worker, to assist with some of these linkages and take a little bit of the guesswork and the cold calling off of your plate as a caregiver.
Right, that's a great point. Yeah, if I can just add to that, I think if anyone is currently receiving any kind of home care services, you should just simply ask if there's a palliative care service line attached with that company or hospital. I think that's a really great point.
And you mentioned, Ellen, hospice care, and I think that's worth elaborating a little bit more if somebody wouldn't mind talking about that, because palliative care and hospice care do get so often confused with each other, or folks think that, you know, they're eligible for one and not the other. Can you just highlight the differences for us and let us know, can we receive hospice and palliative care at the same time? Is that something that happens, or is it usually one or the other?
I can start off and then certainly defer to my colleagues here. All hospice care is palliative in that the goal is symptom management, but not all palliative care is hospice. So someone choosing to elect their hospice benefits, say under Medicare or another insurance, their doctor has certified that the illness, should it take its course, our life expectancy is 6 months. And also we've chosen to focus on comfort and symptom management as opposed to aggressive interventions at this time. It's not stopping care. That's a very big misconception, if I may. It is shifting the focus of care to symptom management and comfort. So that's where I would start in a nutshell. And I know my colleagues can expand on that from a more medical perspective.
Yeah, I can hop in. The admission criteria for hospice is anyone with a prognosis of 6 months or less. How did we come up with 6 months? That's a long story, but essentially back in the early 80s, a bunch of congressmen just came up with this 6-month benefit. But it's important to talk about, because for some, they would not elect hospice care until a very, very final time in life. They're not interested in 6 months out. For other people, my mom, for example, who's still alive in her 80s, does not want to see the inside of a hospital if she's in her final 1 year of life. She doesn't want any kind of life prolonging care. So everyone is different. So we shouldn't be locked into the 6-month prognosis thing, but it is important to understand that 2 doctors need to certify or say, yes, indeed, I believe this person may be in their final 6 months of life for them to be hospice eligible and receive hospice benefits, which Ellen just pointed out is only treatment for comfort. But palliative medicine may precede that and may be offered concurrently or at the same time with curative care. And it's worth just mentioning who Dame Cicely Saunders is. Dame Cicely Saunders is she's passed on now, but she's really the founder of the modern hospice and palliative medicine movement. And back in the 40s in England, she started the first hospice. And she was a very special person. She trained as a nurse and then as a social worker. I may not have that in the right order, but then as a physician. So she was a social worker, nurse, and physician all rolled into one person. And she was able to really articulate and describe the kind of suffering, I think, that someone experiences when they're entering a final phase. And she described it as total pain. So not just physical pain, but psychological pain and the pain that the family experiences. And she argued for this more comprehensive, holistic approach to treat that person and their family. So it's really, that's what hospice does. It's a very holistic approach that treats the patient and the family. And it's made up of, so like Yusumi was pointing out, a multidisciplinary team. Doctor, nurse practitioner, perhaps a social worker, chaplain, volunteers, pharmacists, sometimes a physical therapist, but it's a multimodality approach to treating someone's suffering and treating family suffering. palliative medicine kind of grew out of that. So that's just what we do. It's a multidisciplinary approach offering the same kind of care, but for that person who is not enrolled in hospice or continuing so-called curative life prolonging care.
And it might be helpful for folks to just 1 second, I just want to not lose that thought, but it might be helpful for folks to know what you mean when you say curative care, because that might be a new term for those who are joining us today. So what does curative care mean? What does that include?
Yeah, so what I mean by that is using an antibiotic to treat a pneumonia or to treat a urinary tract infection, or continuing chemotherapy to treat a cancer, or medications for heart failure or pulmonary disease. Or getting blood tests and x-rays and so on, wanting to pursue investigations to treat medical problems, either existing or that come up. Once someone is enrolled in hospice, we don't do those tests anymore. We just look at the patient and treat the patient's suffering based on the exam and the complaints or concerns that the patient or family have. We don't do an x-ray, we don't do a lab test or anything like that. We just do aggressive treatment of symptoms, pain, nausea, insomnia, and so on, just to make the person comfortable. In palliative medicine, we're doing that, we're treating the symptoms, but that person may also still be going to the oncologist to check the blood test, or still be going into for radiation. If they're getting radiation to a tumor, they'll still continue those kind of treatments.
Great, thank you for clearing that up. I think it's just really important for folks to understand the kind of care that they can continue to receive with palliative services. And you see me, I'm sorry, did you have a thought to add here?
That's okay. I agree with what everybody has said. And I just want to focus too that sometimes something acute could happen that changes your whole life. So for example, somebody has a stroke and they were completely independent and living home alone. And now they have some deficits and the families are going to have to be the caregiver. And during that acute phase, palliative care does come in sometimes and help with support and resources. And then as things calm down, if they're stable, we can continue to follow. So I think the main thing is that they don't necessarily have to have, death is not imminent. You're continuing to get your standard treatment. You're continuing to see your doctors. And there are times that there's these acute events that really cause a lot of stress to the patients or the families. And we are there, even for that short period of time, to get them through that. And then they can go on. And so we do have some people that come on and off service, depending on how they're doing. Dementia happens to be another big one where we know that there are changes that happen over time. And sometimes when something acute happens, again, now the person is not doing well and we don't know what to do. And so we go in as that additional layer of support.
Right. Layer of support, I think, is key. And that really sums it up, I think. And to kind of dumb it down a little bit, and I hope I don't offend anybody on the call, but it's palliative care. In palliative care, we essentially are doing two things. The first, managing symptoms. So we have expertise in treating all of the symptoms of that may be happening: pain, nausea, weakness, anorexia, not eating, things like that. So we have expertise in treating symptoms to get people feeling better. The other big thing that we do, the second big thing, is we talk to people and we share information about prognosis. And within the context of the prognosis, we try to find out what's important during that time. And that's what I mean by it, everyone is different. So we hear different goals of care. And in the same prognosis, we may hear different things. And then we try to align care to meet those stated goals. So we have family meetings, we talk, we break bad news, we do goal setting, and we're really good at communicating and goal setting and managing all of the consultants and so on, so that the patients get the care they want and avoid the care they don't want, and treat symptoms. So I really think those, and maybe you guys can expand on that, but I'm a simple person and I kind of like to describe what I do for a living in simple terms. And that's essentially what we do. Would you guys agree with that? Or expand
Absolutely.
on that? Yeah.
Absolutely. And I love Dr. Briel's point about all of us coming and aligning with those goals and values that the patient has. And with the holistic interdisciplinary team approach, we're doing that under the context of, again, goals, values, ethnic and cultural considerations, spiritual, as was mentioned before. And to me, really educating yourself, thank you all for doing that by attending this session, but it becomes a bit of a social justice issue for me as a social worker, ensuring that this information is out there and that you are knowledgeable about all the benefits. And again, so that that treatment is really aligned with who you are, what those goals and values are. So, yeah.
Started kind of leading into what was going to be my next question. You talked about some good points there on what kind of care in terms of making sure that your goals are.
Hi, Alyssa, you're in and out.
Something's going on with your mic.
No.
Something with the mic. Yeah, it's just a little crackly. You want it, maybe if you turned your camera off and just use the mic for a moment, just to test the sound. It's still a little crackly.
All right, guys. Better there?
No,
Oh,
it's still a little crackly. Maybe we'll just talk.
Maybe you could type in the question in the chat box and we can try to answer it while we fix your microphone.
Yeah.
Yeah.
Someone suggested to mute and unmute, but still a little crackly. Let's see if there's something in the Q&A. Maybe folks can start typing in some questions now. How does one qualify for palliative care? Yeah, that's a question, a good question. I think we answered that, but there are a lot of different definitions about palliative care floating out there, but it's essentially reserved for people with a serious medical illness who have to face some serious decisions and may be faced with a lot of symptoms that they're struggling with. I think that's, and whether it's a life-limiting disease or not, that we can argue or debate that. What I mean by life-limiting is that it may shorten your life expectancy, any number of years, but that's what we mean by life-limiting. And try signing out and signing back in. I think she's doing that now.
Okay.
Yeah, and Annalisa made me the host. Maybe that'll help.
Okay. Yeah.
Oh, she's back in.
Okay, we're taking turns being the host.
No worries. It's not better now.
Much better.
Thanks. Sorry about that. I did hear you answer the question, so that was great. But I just wanted to take it back to what you were talking about before, Dr. Burrill, because you brought up some really good points about making sure that they align with the palliative care is aligning with the goals of the patient. And I think that's a good conversation about what high quality palliative care looks like, what type of care and support should we expect to receive. This may be the first time folks are hearing about palliative care. They may not know what to expect. And as we know, care really differs from one provider to the next. And so we've talked about a lot of components, but maybe we can kind of recap it for everyone in one section here on what high quality palliative care looks like.
Right, and again, this disclaimer, I worry about access. So even in the best of hospitals with a robust palliative care service, it's really hard to meet this goal. But ideally, what a palliative care experience might be like for that patient or practitioner, we're looking at the patient as a whole. We're looking at the family as a whole, and our primary goal is to relieve suffering, right? And so we need to get to know the patient, because they may be complaining of a 7 out of 10 pain, and that's just a number, and we can just prescribe a narcotic for that number, and you can get Dilaudid or morphine or so on. but there may be more to that pain that we need to know about that person's previous experience, about the previous the psychosocial makeup. So looking at the patient in the context of their life, their family, taking a very holistic approach, ideally is what palliative care should be doing, because as Dame Cicely Saunders pointed out, it's more than just that number, the 8 out of 10 pain. There's a lot of suffering that happens. And there's a lot of, we all know, we all have families and friends, we all know about the dynamics within that family. That needs to be addressed. But I think that a good, robust palliative care service would include a multidisciplinary team and would include nurses, doctors, social workers, chaplaincy service, if that's appropriate. So looking at the whole biopsychosocial, spiritual suffering of that person, and how can we help them feel better and get back on track to receive more care or meet their goals. It's a very, idealistic and lofty goal, but it makes absolute sense. And I think the reason why it's become so popular and so needed, I think, sadly, is because of what I call the disintegration of medicine and fragmentation of medicine. I'm sure everybody on this call knows about this or have experienced this. Doctors don't talk to each other very well, and we're not communicating well. And the subspecialists, the specialists are driving the medical decision-making. I had a patient experience just a couple of weeks ago. I met a very healthy 80-year-old out in the community, my patient for a year. I just met this woman, very high functioning. And she came in with some rectal bleeding, and I did an exam, and she had hemorrhoids. It was obvious she had hemorrhoids. I sent her to a GI doctor. And a month later, I got a call from this woman asking if I've reviewed her scans and what do I think? And I thought, what scans? She went to the GI doctor and they did a flex sig scope and they saw a tumor. Then they sent her to a surgical cancer specialist who did a bunch of scans and recommended radiation. And she had an appointment with a radiation oncologist, and she just wanted me to double check if that was the right thing to do. And I thought, holy cow, and that's typical for New Jersey. I think maybe typical for the rest of the country too, but we have fragmented care here. And this woman was together enough to know to call me, right? I didn't hear from the other doctors, but if you have frailty, or if you have dementia, or if you have decision makers, caregivers who are trying to be the quarterback and they're out of state, it's really hard to do. I think that's what palliative medicine does, is it brings the whole patient back into focus, right? Where the primary care doctor might have in the old days, might have done that, no longer able to do that in modern medicine. I think that's why it's been so popular and so successful.
And I just want to reiterate the points that you made earlier too about what high quality palliative care looks like. It's that shared decision-making approach and that culturally sensitive care. So again, it's aligning with your culture, your beliefs, your goals, your values, and it's not your healthcare team making decisions for you. You're very much a part of the conversation and ultimately the decisions that are being made and the type of care that you are receiving. And so definitely feeling comfortable and willing to speak up for yourself. Or as a caregiver, speaking up for those that you're caring for, if you know that they do or do not want certain types of care, those are really important components of palliative care.
The cultural piece is really important, and maybe Ellen wants, or you see me want to expand on this too. I often talk about my parents. First, New Jersey is culturally diverse, right? Where I think we're the third most culturally diverse state. We're the most culturally diverse amongst physicians. So that creates a challenge. I often talk about my own family. So I told you guys about my mom. My dad died years ago. My dad was the kind of patient who wanted everything done. He had a metastatic cancer and he got radiation. He got a lot of aggressive treatment because he wanted to live as many days as he could, regardless of how burdensome the care was, right? The medical treatment. And he just wanted to squeeze out as much life. He was only on hospice for a couple of days. My mom doesn't want to see the inside of a hospital, but both of them immigrated from Italy, met and married in New York City, same type of people, same social interests, same type of friends, but two totally different opinions about the kind of care they want in their final phase of life. So that's why it's just so important. Even in the context of different cultures, it's important to understand what some cultural beliefs are. But I think family culture, right, is really, really important. And what that individual person wants for themselves is really, really important. And that's what makes this kind of work kind of interesting.
And to add to that a little bit, we are trying now, and we have, but paying more attention now to the underserved community. How do we get them access to palliative care? We've also been trying to do some work with our LGBTQIA community, and how do we get them involved? There's always, I guess, maybe some distrust with us, or can we culturally understand where they're coming from? So this is education that we're doing on our part, and trying to partner with them to really be able to understand what their needs are, because that's what's important to us. What are your needs and how can we help you? So that is something that we're now looking at a lot.
And I'm glad you brought that up, Yusimi, because provider education is such a big component. As much as we're all talking about how great it is that we have all the participants with us today learning more for themselves, that provider learning component is especially important. And we actually had a question related to that come in, and an attendee asks, are the medical and nursing students being trained on palliative care?
That is a great question. And from the nursing perspective, we know that we are trying to, even from the consortium piece, partner with the universities and the colleges in the state to try to make sure that palliative care is part of the training. I have to be honest, I don't think that there's much that's going on, but it's more than it was before. We're having a lot of new physicians who are coming into our organization that are feeling more comfortable about having goals of care discussions that we did in the past. So it is a hot topic, and we are trying. COVID changed this a lot over the last 2 years, where people who did not feel comfortable with these difficult conversations have now had to embrace it and start to practice it. And the more we practice it, the better we get at it. But even within symptom management, refractory dyspnea, we use medications at doses that other people would not feel as comfortable using. And we are continuing to do that education to bring all the clinicians up to speed as quickly as possible. Dr. Burrell, I don't know if you have any additional input there.
Yell and scream about this topic for the rest of this webinar, sorry. But I think obviously we're not doing a good job educating our young doctors. I think we're doing a better job at educating nurses, I think, and in nursing school, they probably receive more information on this than in medical school and residency trainings. But I think the medical educational system has failed us. And I think, and I ask myself this question all the time, we created this whole subspecialty that is palliative medicine. And I often wonder, gosh, over the last 20 years, maybe we should have embedded this stuff better into the general medical curricula and residency training so that doctors leave a little more experienced with these kind of skills of treating symptoms and establishing goals of care, because it's just good doctoring, right? It's just good medicine. Treating people's symptoms. When I prescribe an antibiotic for a urinary tract infection and simultaneously prescribe pyridium, which is a urinary analgesic, it helps ease the pain, for a young woman, that's a palliative act. We're treating the symptoms, right? It's really not much different than what we're doing in palliative care. So we're not doing a good enough job teaching the young doctors in training. And that's probably, I think, a lot of what's happening in medical education is they're getting primed to be specialists. So it's just increasing this fragmentation more. But we're not going to turn that big ship around very quickly. But there's some hope, I think.
I love that example that you use regarding the urinary tract infection treatment, because that is such a great example of palliative care, and we don't talk about those examples enough. And so that's why a lot of people do tend to think of palliative care being only at the end of life. And it's like, you're receiving palliative care since the day you were born. You just don't know that because we don't call it that.
Right, exactly.
And I did just want to circle back to the points that you guys brought up about including family members and other people who matter most to us in these conversations. And of course, the whole focus of today's session is also on that caregiver role. And a lot of people really don't know that palliative care can be a great resource for caregivers. And Ellen, I was really hoping that you could maybe talk to us a little bit about, why caregivers might need the support or how palliative care can help support them in their role as a caregiver.
Sure. I like Dr. Burrell's metaphor of the quarterback. I've been thinking about it in terms of our navigator and our co-pilot. And our caregivers are our co-pilots. They are not just a body sitting in the chair bedside. They are not just standing in the patient's room as an outside observer. They're active participants in the care, which I think is a point very well made, again, earlier. By my colleagues. And going back quickly to the point about not only does PAL care manage the symptoms, but we talk, we need to learn how to talk to the family members, because I may go in and I think the high quality palliative care looks like culturally competent, patient-centered, compassionate care, which it is. And I want to start from this patient-centered. I want the patient navigating, being that quarterback, throwing the balls, calling the plays. But that client, that patient, their decision-making process may be very different from mine. They may defer to eldest adult male. They may defer to someone else. So I need to glean from the clients how those decisions are made and who needs to be part of the conversation. So that's, again, where our caregivers come in. And I think that the metaphor about the empty vessel, or a vessel, and when we're pouring out, providing care, we're providing emotional support to our client, we're providing physical care. We ask a lot of you. I am not a nurse, but if I need to do the wound care for my loved one when my nurse is not there, that is a skill that I have never experienced before and never thought I would. And it's completely new and foreign and scary. So by equipping our caregivers with the resources and support, they're able to do a better job. Again, going back, they're pouring out that vessel, their emotional support, like I said, their physical support, they're administering medications, they're administering narcotics that they never thought that they would be giving to their loved one. They're expending a lot of physical energy, financial costs of providing care. If we do not take care of that caregiver, they are going to deplete. I don't have the statistics with me, but we know that the caregivers are at risk as well for their emotional and physical well-being. So with PAL care coming in and being this extra, what did we say earlier, layer of support, we're able to equip the caregivers, not only through support, not only by providing permission, which I'm going to do today to our caregivers, to ask for help and take a break when you need it, because I'm going to come in as a social worker and I'm going to educate you about some of the resources that are available in the community. And you can use these things to care for your loved one while you care for yourself. And that self-care element for the caregivers is so important. I'm not just talking to spa, massages are great. And there's that element of self-care, but sometimes self-care for our caregivers is saying no, or setting a boundary, or asking for help. So how's that as a start for our caregivers and their needs? The more we equip them, the more we give them, the more tools, the more education, the more conversation, the better able to do your job. And for a longer period of time, you're going to be able to do it.
And you mentioned a great point, right? Is that we all need breaks. And especially when you're caring for a loved one, it is a lot of physical and emotional, task that you're taking on. And so what if you are a caregiver or you're the patient and you have people who help take care of you and they need a break, but can't quite leave you alone for any period of time? Are there any programs or services available that can help a caregiver in that setting who needs to take a break, but still will need somebody to kind of come in and step in for them to take care of their loved one, family, friend, or patient client?
There are, and the resource sheet, Lisa, that's going to be sent after. The best place to start is your area Aging and Disability Resource Center. All 21 counties in New Jersey have an Office on Aging or an ADRC. that is a great place to start. Now, going back to Dr. Bareil's example about accessibility of palliative care, the programs that are available often have financial criteria. So they're looking at your income and your assets. So I want to be very clear that we don't just call the County Office on Aging, hey, I need a break, what's available to me? Although that's the perfectly adequate way to start, but they're going to indicate that there's an assessment and that financial criteria need to be met. So what I think you're really talking about, Adelisa, is respite services, which, by the way, regular Medicare does not provide for respite services. The only respite services where, say, the caregiver can get a break for up to 5 overnights is under the Medicare hospice benefit. So that's something to tuck away in the back of your mind. But again, the County Offices on Aging, it's a statewide respite program that somebody might be able to tap into to either take a break just because they need a break, or to attend a family event that they're able to attend and their loved one, their identified patient, is not. Or that respite could look a little more structured, maybe somebody coming in 3 times a week. We haven't mentioned home health aid within the context of home care or palliative or hospice. These workers are the backbone of care at home, in my opinion. The person who's coming in and assisting with personal care, bathing, dressing, feeding. That's also another strong support for the caregiver. So I would definitely start with the local offices on aging. There's of course private hire services, and things were different over the last 1.5 years with COVID, as agencies wanted to ensure the safety of their staff and of course the client and the family members in the home. But with screening and proper PPE, I've seen the industry kind of bounce back and be able to provide that assistance.
Great, thank you. That's great information to know. And I do love that you brought up the cost aspect of it, because some programs do require you to meet certain financial targets. But if you are able to afford hiring a private aide or a home health aide, there are those options available for you as well. And I think it's also worthwhile talking about about an advance directive, just a little bit, if somebody wants to touch on that, because, we talk a lot about palliative care and our wishes and our goals, and really that advance directive is an opportunity to capture some of that information, to be able to share it with your other providers and those who matter most to you. Can anyone just kind of really quickly highlight what an advance directive is or how we go about getting one?
Yeah, I can jump in. Before that, though, just to expand on Ellen's point, the other thing that you can do as a caregiver is to look for disease-specific organizations or foundations. So, for example, if you're caring for someone with Alzheimer's, not the Alzheimer's Association, the national group, but New Jersey has a really good Alzheimer nonprofit. It's called Alzheimer's New Jersey, alznj.org, I think is the website, and they have a lot of good support services. They have a stipend that you can apply for to help with care for a week, if you need to get out of town or just a break and so on. So a lot of good support services. So think about, what the primary diagnosis is and look online for any organizations or foundations that might offer some support. But yeah, advanced care planning is really important, getting the information down on paper of what you want and don't want. So all of us, all healthy adults should have a living will or advance directive. Really easy to do. You don't need a lawyer for that. Please, no one pay a lawyer. We need lawyers for some things in life. We do not need a lawyer for an advance directive. You can just the New Jersey Department of Health has one. 5 Wishes is fine. You can download it, do it for yourself. One of, I think, the most important things on that directive is to assign a healthcare proxy or decision maker. And that's really important, and to have a discussion with that person about your preferences, more like my mom, more like my dad, that needs to be clarified. But really importantly, for those people entering their final few years of life, if we're caring for somebody and the doctors think that this person may be in their final few years of life, that person should have a POLST form. That's POLST, Practitioner Orders for Life-Sustaining Treatment. And that is a single page set of medical orders that the practitioner fills out, either nurse practitioner, PA, or doctor. And it's a set of medical orders that describe things like, do I want to go back to the hospital? And what to do when the heart stops? Do the EMTs do CPR or not allow a natural death, and so on? The fascinating thing about PULSed and the power of having a PULSE form is that it's portable. It's an active medical order on your refrigerator door. If the EMTs arrive and they see allow natural death, no CPR, they will not do CPR. If that person just has a living will, an advance directive, and it says, I just want to be comfortable, I don't want machines, the EMTs by law are obligated to do CPR. They can only follow a medical order. So that's why the PULSE form is so important. And it's portable. So it's an actionable medical order in the community. If that person goes into the hospital, it's a medical order there. In the nursing home, most people in a nursing home in long-term care should have a PULSE form. People entering their final few years of life should have a PULSE form. And maybe may I use this opportunity to promote Goals of Care on the website?
Yes, of course, you have great resources, so definitely share.
The resource, so if you look at goalsofcare.org, that's our home website. Goals of Care Coalition of New Jersey is a nonprofit made up of over 30 organizations, really intended to help with promote palliative medicine services across the state. And on that website, you'll find something called the iCare Plan, which is a 4-step method for medical decision-making. Doc, what is my diagnosis? Doc, what's my prognosis? Step 3, these are my goals. Step 4, how are you going to treat to achieve these personal goals? It's kind of a script to use when visiting the doctor. You'll also find a lot of information under the Let's Talk module, a lot of videos that describe advanced care planning, and a lot of stuff on PULSE. So if you just look at goalsofcare.org and go to PULSE and just watch the first video, I think it's all right there.
If I may, Annalisa,
yeah.
If I may just underscore what Dr. Burrell said and what we've been saying all along, kind of tie back into the benefits of this interdisciplinary team in PalCare. If I go in with Yusemi and she's talking about the elements of the PULSE that are very medical, what it'll look like to have CPR and these interventions. I want to partner with her as a social worker to talk about what's the meaning of these decisions for you as an individual, as a family, as a member of your community, and your beliefs. So that partnering up where we're able to address the medical piece of the decision making, as well as the more emotional, psychological piece, is where I think we really are worth our salt as a team.
I think we mentioned.
Sorry, just to add on to that real quick, you mentioned the emotional piece of this, and a lot of people are very hesitant to even have this discussion. But I always think of it that it is a gift that you're going to give your loved one if you give them that information, because when an emergency happens and they're struggling with what to do, they can fall back on the fact that they know you as that person, and this is what you would have wanted. There is another reference, it's called the Conversation Project. And they also have a website that helps you to try to analyze yourself and what would be important for you to let your families know. And the other piece is that even when you complete that advance directive, go back and review it often. As we change, our thoughts change, our goals change. What I feel now may not be what I'm going to feel 30 years from now. And it is important for your family to know where you are, because I do get a lot of people who have come in that the advance directive was done in 1970, and they'll tell me that they had no idea what they were signing back then. And that's not what mom would want now. But if you have a recent discussion, then at least they can fall back on that. And I always consider that to be a gift.
And with Thanksgiving coming up, there's a national incentive for turkey talk, right? So at the Thanksgiving to bring this up.
Well, thank you all for a wonderful discussion. I invite our participants or attendees to today's webinar to please feel free to type in any questions you might have into the Q&A box or the chat box so that we can answer them. And while we give folks a few minutes to do that, I just want to let everyone know, because I did have a couple of questions come through about a lot of the resources that we talked about today. Following today's event, I'm going to be sending out an email to all of you in the next day or two that will have a link to this recorded webinar, as well as links to many of the resources that we discussed today. I also want you to know about our COYL webpage, and that's where you can also find information and really steps to help you walk you through this advanced care planning journey. You can learn more about palliative care, as well as other thoughts about considering your goals and wishes for care, and strategies for how you can comfortably approach these important conversations with those who matter most. And then our COYL website also has our upcoming COYL programs. And so we update that regularly, as well as with new resources. So be sure to check those out after today's event. I'll include that website link as well in that follow-up email. We did have one question come through, and I actually received a question prior to today's session that I wanted to make sure I asked you all as well. But the question for today is, somebody just asked about what was the Pulse website again? Would somebody just be willing to say it out loud? I'm going to include it, but just for them.
Just type that in. It's goalsofcare.org, GOALSOFCARE, goalsofcare.org. And that's our organization. The Pulse Forum is actually owned and distributed by New Jersey Hospital Association. So if you want to look at their website, but there are more resources on Goals of Care. The other thing to mention is that there is a national organization. Their website is pulsed.org. Now, each state has their own Pulse form, and they don't all call it Pulse. So it's a little messy nationally. But if you have an interest in, if you have a loved one that lives in California, for example, and you want to look and see if they have a Pulse form, they do, by the way, and it's a little different from ours, but you'd go to pulsed.org. But locally, it's Goals of Care.
Great, thank you. And the question that I received before today's session was someone asking about telehealth, because they heard a lot of people talking about telehealth services during the pandemic that allow them to still be able to see their doctor virtually. And they were wondering if that's an option for palliative care. So I wanted to make sure I mentioned, ask that question live and see if you guys had information you could share about telehealth as it relates to receiving palliative care services.
We do. I can talk a little bit about that. So for our home program, and even in our office, we do use telehealth. Of course, depending on our patient population and access, not everybody may have that access, but we'll even sometimes, check in with people over the phone. But we've tried to encourage that so that we can continue to stay in contact with our family members. So for our office and our home program, we do use telehealth if needed. And I think that's pretty much still okay throughout the state of New Jersey with all the different changes that were made after COVID.
Ellen, did you have something to?
Yeah, just as an offshoot of that in terms of telehealth, a little separate from telehealth specifically for palliative care, but there are a lot of support resources being provided virtually, whether that's in the form of a caregiver support group, so you can do it right from home, often via Zoom or whatever platform that they use. So you can have a forum for sharing that shared experience of caregivers with others in similar situation, and also for individual counseling as well is also available virtually. And a lot of folks hesitate. I know I did myself. I'm old school. I want to be face to face, but it's been proving very, very effective and convenient. So.
Well, I see we're a minute over, so I want to thank you all for a wonderful discussion, and thank you to all of our participants for joining today. We certainly learned a lot of information about palliative care and how to access it and what it looks like, and especially a lot of resources both for patients and as for those of us who are caregivers. Again, I will send out an email after today's event in the next day, probably with a lot of the links to the resources that we discussed, as well as this webinar recording. And you can also feel free to email me back if you had any questions that you didn't have an opportunity to ask during today's session. I'll be sure to get that answer back to you. So thank you again, everyone, for your time, and I hope you enjoy the rest of your day.
Thank you.
Bye, take care.
Adelisa, should I stop recording? Am I still host?
No, I should be the host now, but let me just make sure.
Okay.
Yes, I am the host, so you are good to go. Thanks.
Good to see you. Take care.
Thanks to see you.
Yeah.